Hey, welcome everyone. I'm Carrie Tirado-Brayman, Director of the UB Gender Institute and a professor in the English department here at UB. Thanks so much for joining us today. I want to encourage you to join our listserv, and we'll put that information in the chat box. Before we begin, I would like to acknowledge the land upon which the University of Buffalo operates, which is the territory of the Seneca Nation, a member of the Haudenosaunee Six Nations Confederacy. Today, this region is still home to the Haudenosaunee people, and we are grateful for the opportunity to live, work, and share ideas in this territory. Today's talk is part of our lunchtime series called the Feminist Research Alliance, which is now in its 11th year. And this is the first time since I've been director that we've had a speaker from the medical school. So I'm thrilled to welcome Dr. Ann Curtis, who is a SUNY Distinguished Professor, Charles and Mary Bauer Professor of Medicine, and Chair of the Department of Medicine in the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. She's one of the top cardiologists in the US. In fact, I'll share with you this, a fun fact, since it's World Series season. One of her most famous patients was Ted Williams, the baseball legend, whose pacemaker operation made headlines in the Hollywood Reporter. I first came across Dr. Curtis's work in an essay that she co-authored in Nature Medicine in March 2022, and we'll put that link in the chat box. And it's about the impact that the COVID pandemic was having on women in academic medicine almost immediately. How grant submissions, for instance, declined for female faculty in internal medicine, that women with children were less likely to accept leadership positions, and that the number of women in academic medicine starts to decrease the more senior the rank. Dr. Curtis is past president of the Heart Rhythm Society and a recipient of their Distinguished Service Award and the President's Award. She is past president of the Cardiac Electrophysiology Society and the Association of University Cardiologists, and she is president-elect of the Association of Professors of Medicine. Congratulations on that. She's on numerous editorial boards in cardiology and electrophysiology, and she has over 340 peer-reviewed publications, book chapters, and reviews. Today, Dr. Curtis will discuss her research on gender disparities in the management of patients with cardiac arrhythmias. Welcome, Dr. Curtis, to the Virtual Gender Institute.
Thank you, Carrie. It's a pleasure to be here, and hopefully this is all going to work out well. Because as I mentioned, this is a talk for the Feminist Research Alliance, but also for our Department of Medicine's grand rounds. And so because of that, I've got a mix here of medical terminology and facts, as well as more social issues. And I will try my best to explain the medicine to those who are a little bit less familiar with it as we go along. So my goal here today is to talk about sex differences and disparities in the management of cardiac arrhythmias. And those words are chosen very carefully. These are my disclosures, as we usually do for medical talks. So these are my goals for the next 45, 50 minutes or so. There truly are biological differences between men and women with respect to the heart and arrhythmias and the way that the cells in the heart and the electronic currents work that are worth highlighting because they drive some of the differences that we see. I'll speak then about sex-specific differences in the incidence and clinical presentation of various cardiac arrhythmias, and then switch over to gender differences in the management of patients with cardiac arrhythmias that lead to disparities in care. And so now the first thing I want to specify is that there is a difference between sex and gender in the way those terms should be used. I see gender a lot used in medicine, whereas sex is often the more appropriate term. Sex is biologically defined, and it refers to biological aspects of an individual. And that's determined by anatomy, by the chromosomes, the hormones, and sex is assigned at birth. It means you're male or female, and it's a biological construct. Gender is social, and it's related to behaviors and attributes based on labels of masculinity and femininity. So some of what I talk about are sex differences, and others are actually gender differences, and I'll try to highlight that as we go through. So when we look at the mechanisms of sex-based differences in the heart, as I mentioned, there are a number of different areas where they can come up. So sex hormones are pretty obvious. There are genetic differences. The genes are different between men and women. But in medicine, we look at other factors as well. So I will go ion channels and action potentials. The heart has an electrical system. And that's what drives the signals to make our hearts beat: fast, slow, normal, abnormal. And there are ionic channels that drive that. I'll go through in just a little bit more detail. But the cells have different energetics and metabolism. We have different hemodynamics between men and women. Autonomic tone is the body's nervous system and how it interacts with the heart. And they all contribute to these differences. I'm showing here an action potential. And again, for the non-medical people here, every heartbeat that we have, every single one of us right now, they are started by what's called an action potential, and it is an electrical signal that starts from a baseline that then jumps up and then depolarizes the heart, which then eventually causes the heart to contract. And then there's a duration of time, and then we have what's called repolarization, and then the heart relaxes. On the electrocardiogram, we see a signal that looks more like this. So the medical people here will recognize this as an ECG signal that has atrial activity, ventricular activity, and then ventricular repolarization. And you can see how this times to the heart's action potential. Now, what I'm showing here is the difference between men and women. And the most important one from the aspect of the propensity towards arrhythmias is this factor over here, where the action potential in women in general is longer than that in men. And it does have very specific effects on arrhythmias. For the medical people, this has to do with potassium currents. And when you have less potassium current, you're not going to repolarize as fast. This is what leads to QT prolongation on the electrocardiogram and the propensity towards arrhythmias such as torsade de pointe. I'll go into that again a little bit later. So that's a very fundamental sex-based biological difference between men and women. Now, if we were to look at the electrocardiogram, which would be more familiar to those, all those in the audience who have either had them or seen them over time, there are a lot of measurements that we make on here. And I'll just highlight just a very limited number of them. But this is one, we have activity from the atria, from the ventricles, and from repolarization. I'm going to highlight QRS duration. This is one of the components of the electrocardiogram that governs the depolarization and repolarization of the heart. And these intervals are shorter in women than in men. And that has a direct impact when I get to the point of talking about something called cardiac resynchronization therapy. Some of the other differences, there's another important one, which is the QT interval. And you can see in women, they tend to be shorter than in men. And there are autonomic tonal differences that contribute to this as well. So we know just in general that there are differences in the measurements that you could make in a normal electrocardiogram that are different between men and women. So with that as a background, supraventricular arrhythmias, we use the term supraventricular and ventricular to distinguish between those that involve the AV node and the atria, the upper chambers of the heart, versus the ventricles, the lower chambers. So first, with those supraventricular arrhythmias, which tend to be benign, they are in most cases benign, but a real nuisance for patients. There are different types that we see, and as an electrophysiologist, I do see patients with all of these kinds of arrhythmias. There is something called inappropriate sinus tachycardia. And again, for the non-medical people, sinus rhythm is the heart's normal rhythm. When we say sinus tachycardia, we mean the heart rate's going faster than 100 beats per minute. Sinus tachycardia is normal if you're jogging or running on a treadmill. It's inappropriate when you're sedentary, you're not doing very much, and your heart rate's very elevated. That's an abnormal condition that we see almost exclusively in women. And it's not well understood why that is. And there's also a condition called postural orthostatic tachycardia syndrome, or POTS for short, that's also much more common in women. There are a couple of other different supraventricular arrhythmias that are important to electrophysiologists because of the fact that they are highly curable with a procedure called catheter ablation. And we know that AV nodal reentrant tachycardia is much more common in women than men, and reentrant tachycardia is related to Wolff-Parkinson-White syndrome are much more common in men than women. And so when I see men and women who have, or say women who have rapid heart rates, I can usually guess that they're going to be more likely this kind just because of the frequency distribution that we see. And so if you were to look at patients who have cardiac arrhythmias, who get referred for curative procedures called electrophysiologic studies and radiofrequency ablation, the frequency of the different types of arrhythmias are different with this kind of a distribution as you see here. And again, this is more technical and more related to those who work in cardiology and electrophysiology, but they help us in planning the procedures and also in advising patients about the potential risks of the procedure, depending on where we think we're going to have to do the work in the heart to cure it, and the expected outcomes. A much more common arrhythmia is atrial fibrillation. I'd venture to say that out of everybody who's listening today, there's got to be at least somebody who's got it in this audience. And it is a rapid, irregular rhythm that originates in the upper chambers of the heart. It can lead to, the patients can have very rapid heart rates. It can lead to symptoms such as palpitations, shortness of breath, fatigue, exercise intolerance. And it can be related to stroke because when patients have atrial fibrillation, the top chamber is beat in an erratic fashion. Blood doesn't flow through to the heart well. And then what happens is that clots can form. And if they break off and go to the brain, they can cause strokes. So what causes atrial fibrillation? I mentioned that it comes from the upper chambers of the heart. We know that structural abnormalities can contribute to it. So, for example, when patients have valve problems, the heart has 4 valves, and if they leak or they're tight, it can lead to enlargement of the chambers of the heart, scarring of them, and then create the milieu for these kinds of arrhythmias. There are ectopic foci, so actual little areas in the heart and in the pulmonary veins, the veins that drain blood from the lungs back into the heart, that can fire abnormally and also kick off these arrhythmias. And there's a couple of other things as well. So we know that there are various mechanisms that contribute to causing this arrhythmia that is associated with a lot of morbidity and actually increased mortality. And it is the most common cardiac arrhythmia we see in patients admitted to the hospital. And so it's a big problem that we have to deal with. So what's the what is the epidemiology of this arrhythmia? The incidence is lower in women than in men. You can see the ratios 1 to 1.5. The prevalence remains about the same as we age, but because women have greater longevity, there are more women with atrial fibrillation in the elderly population. And if I looked at all patients over the age of 80, about 9% of the population has atrial fibrillation. So it's a very, very common condition. Women with AFib, for the reasons I just mentioned, tend to be older. They have a lower quality of life. They have more comorbidities such as heart failure than men, and they have more symptoms. We have in medicine a risk scoring system. We call it CHADS-VASc for short, but it is used to estimate a patient's risk for stroke if they have atrial fibrillation. The higher that score, the more prone you are to stroke. And the CHADS-VASc score has the SC here stands for sex category. And what we mean by that is female sex, because female sex leads to a higher risk of strokes and atrial fibrillation than men. So it is a modifier, and it's an important consideration in how we treat patients with atrial fibrillation. I'm going to switch now to drug therapy. And so when patients have, many medical conditions, but I'm speaking more specifically right now about drugs that affect the heart, that we have pharmacodynamic differences between men and women. So there are issues, things like sex hormones, that's a natural difference. Lower BMI, the body, the size of the BMI related to obesity and normal size. Women are smaller than men. So you take the same dose of a drug in a man and a woman, there's going to be a difference in the impact. We have higher body fat. Autonomic tone, the way the nervous system works, is different between men and women. There are the genetic differences. And then there are certain enzymes in areas where that metabolize drugs that are different between men and women. And those differences in metabolism, some of the drugs that are listed here, these names, some of these are considered antiarrhythmic drugs, so that patients who have the arrhythmias that I've spoken about already may be treated with antiarrhythmic drugs. And if they're going to react differently than men, then you have to be aware of that in terms of monitoring, as well as the doses that we use. The term GFR here is glomerular filtration rate. Basically, it's kidney function. And the lower someone's kidney function, some of these drugs are metabolized by the kidneys. And if they are, that also can indicate that dose adjustments are necessary. And so these differences are important, especially for drugs that have narrow, what we call narrow therapeutic margins, which include the antiarrhythmic drugs. And by that, we mean the difference between the dose and the blood level that's therapeutic versus the one that gets you into trouble is not that different. And so we have to monitor carefully. So when we look at antiarrhythmic drug use in women to treat many of the arrhythmias I mentioned already, the certain antiarrhythmic drugs, and the names are listed here, very common. Amiodarone is a very common one used in the older age groups. These drugs, when used in women, are more prone to causing a potentially lethal arrhythmia called torsade de pointes. If you remember back to the beginning of the talk, and I said that I showed that action potential and how it's longer in women, well, these drugs can make it even longer. And the longer that gets and the longer the QT interval, the more it can kick off what we call a polymorphic ventricular tachycardia that can lead to ventricular fibrillation and cardiac arrest. So that's one reason why we monitor electrocardiograms in patients who are on these arrhythmias. The efficacy of antiarrhythmic drugs is actually pretty comparable between men and women, so that's not a problem. But in general, women are prescribed these drugs less often than men, which may be inappropriate if women are more symptomatic than men are. What I'm showing here, I mentioned that the potential for a dangerous cardiac arrhythmia is more likely in women. This is showing it based on age and men versus women, the risk of getting this kind of a serious ventricular arrhythmia with one particular antiarrhythmic drug that's called sotalol. And it's used for a variety of cardiac arrhythmias. And you can see that across, except in the middle age group, it tends to be much more common in women than men to get these potentially serious arrhythmias. Now, another treatment for atrial fibrillation, aside from drugs, is something called catheter ablation. And I don't have time to go into that in detail, but it can be a curative procedure for this arrhythmia in many people who have the problem. And so it's something that we as electrophysiologists consider very strongly when patients have recurrent episodes of atrial fibrillation, they're symptomatic, and drug therapy isn't working. So women, as I mentioned, have a worse quality of life when they're in this arrhythmia. We don't really understand why, but it's a fact that's been observed. I mentioned that we have more adverse effects from antiarrhythmic drugs, so therefore might be considered better candidates for ablation. And that's a catheter-based procedure that can actually go to the source of where the problem is in the heart, and we either freeze or burn the tissue to cure the arrhythmia. But yet women are less likely to be referred for ablation. They tend to be older at the time of ablation. And that may be a combination of, I mentioned before that women develop the arrhythmia somewhat later than men, and they may be referred later. But if women are sent for catheter ablation, their success rates are the same, but complication rates can be somewhat higher. So these are all things we factor in when we're talking to patients about options for more intensive treatment, such as a catheter ablation. Now let me switch over to sex differences and the risk for sudden cardiac death. And that's an important problem because it's we need to understand the kinds of patients who might be prone to this, because if we can identify them, there are potential treatments that can be implemented. This is, again, this particular slide is for the more medically inclined in the audience, especially for the cardiologists, but there are different kinds of arrhythmias that we see in the ventricles that have higher incidences in men versus women. Again, for sake of time, it's too much to explain, but the most important thing here is to know that sudden cardiac death is more common in men than it is in women. So the Framingham study is a very well-known study that followed a large cohort of patients, men and women, over decades to see how, the epidemiology of various cardiovascular diseases. Very interesting fact is that women have a much lower risk of sudden cardiac death than men when they have coronary heart disease. And you may even think about it. You probably more often hear in newspapers and, just celebrities who die and things like that. When you read that somebody died suddenly, you're more likely to see that it was a man that happened to than a woman, although it's not exclusive, but more common. When women have heart failure, and heart failure can come either because the heart function is weak or it's stiff and non-compliant, with the latter being more common in older age groups. Sudden cardiac death is more common when women have heart failure. It's increased 5 times, but even then, men still have a higher risk of sudden cardiac death. And this is shown here. One of the things we know is that the risk of sudden cardiac death in women lags behind that in men by about 10 years. So what I mean by that is that the risk of sudden cardiac death in a man who's 60 years old is about the same as a woman who's 70 years old. And so it's all shifted, in women to a lower range. And so it's less of a problem. So that's one good sex difference in favor of women compared to men. Here is from another community surveillance study looking at sudden and non-sudden cardiac death adjusted by age and race. And you can see that the risk of sudden death in men is higher than in women, as is non-sudden death. Now, when people have sudden cardiac death, by definition, there's nothing we can look at in terms of what caused it. But when patients have cardiac arrest and they survive it, that gives us an opportunity to see why or what happened. And in men who survive a cardiac arrest, overwhelmingly, they're most likely to have coronary artery disease. So they have, myocardial infarction, or the colloquial term is heart attack, blockages in the coronary arteries, leading to scar tissue, death of heart muscle, and that makes them prone to a cardiac arrest. In women, it's less than half. And they're more likely to have a variety of other cardiac diseases, such as what we call dilated cardiomyopathy, or a weak heart in the absence of having coronary heart disease, and then a bunch of other conditions as well. In the Oregon sudden unexplained death study, and it's been great that there have been some investigators who have looked very carefully at the population risk of sudden cardiac death and looking at the epidemiology of it. Good news is that there was a decline in rates for a period of time. In looking at this population base, 30% of the victims were female. And as I mentioned before, the age tends to be higher in women than in men, and this one not quite the spread that I mentioned before. And then the risks have rebounded for some reason. And here, looking at 3 time periods, you can see that across the board, the risk of women is lower than in men. And so that's an important factor in how we manage this condition. And this is one more example of women versus men in terms of the incidence of sudden cardiac death in men and women. Same group from Oregon. Again, this is more of a medical thing, but for those who have out-of-hospital cardiac arrest, and they get resuscitated, so they go through CPR and they survive. What we see is that the rhythms that are seen are different in men versus women. And the important factor here is that ventricular tachycardia or ventricular fibrillation is more common in men, which means that the survival rate's potentially higher because this is a treatable rhythm often. That's where you shock the heart and you can restore a normal rhythm. Asystole, or lack of any heartbeat whatsoever, or pulseless electrical activity, we all know in medicine that the survival rates from these conditions are very, very low. And unfortunately, they are more prevalent in women. There's something called log QT syndrome. And again, I've mentioned this a couple of times now. The electrocardiogram looks different in women and men. When you use antiarrhythmic drugs, they have a different impact here. And this is where it becomes important. So when we see that, whether you're men or women, on the electrocardiogram, that measured interval that we see that governs repolarization in the heart, there is a genetic condition called log QT syndrome that causes it to be long in people just based on genetics. And it puts, and you don't have to use antiarrhythmic drugs, but yet these events can occur. And actually recognizing this is very, very important because these patients are prone to potentially lethal arrhythmias, and you don't want them to get drugs that are going to potentially even aggravate this more. So the risk of cardiac events in adult women who have log QT syndrome is triple the rate in men. There are different forms of log QT syndrome. It depends on which ion channels involved. And there's differences based on age. So before puberty, there are higher rates in men or boys compared to after that. We know that the sex hormones have direct effects on the QT interval in cardiac events. And based on when drugs are used that can cause log QT syndrome, women are at a higher risk than men are. And this is showing the differences based on whether one is of reproductive age or the transition or postmenopausal. And you can see based on the type of syndrome that someone has, we can tell that there are differences in the likelihood that someone will have an event rate, which could either be just syncope or aborted cardiac arrest on to a lethal arrhythmia. All right, now I'm going to switch to implantable device therapy, and this is going to bring us more towards the issue of disparities. This is a study that I published back, when I was just left the University of Florida. And I looked with one of our cardiology fellows at these are major clinical trials of implantable cardioverter defibrillators. And again, for the lay people in the room, an implantable cardioverter defibrillator, or an ICD, is a device that's implanted underneath the collar, by the collarbone on the chest, with leads in the heart that can prevent a lethal arrhythmia by delivering a shock when the patient goes out of rhythm. And so some of these trials were looking at patients who had already survived an event, and others were looking at patients who were at risk for it and got the device to try to prevent a lethal event. When we look at these studies, the important thing to point out here is that for all of these extremely important studies looking at the potential value of an implantable device to provide life-saving therapy, None of them had very many women in them. So the highest percentage was in a trial called Definite at 29%. And you can see here's one study that only had 8% women. And so because of that, it's actually been difficult for us to understand whether women benefit from these devices to quite the same extent as men do. Because the overwhelming number of people in these studies were men, we do know that there's a benefit. When you have fewer women, statistically, it becomes harder to really tell if there's a difference. And so we highlighted that in this paper. There's a meta-analysis that was done by another group that looked at 5 studies involving almost 1,000 women. And they looked at the effect of this kind of therapy for primary prevention. So, I mean, somebody's got heart failure, they're at risk for having a cardiac arrest, and the device can detect it and shock the heart back to normal, and the patient survives. There actually was no difference in all-cause mortality in women with heart failure who received these devices. And it raises some very interesting questions, and yet it prevents, there's really no way to do a clinical trial today to look at this specifically, because it just would be unethical, because we know of previous studies seem to be life-saving. And so our practice guidelines say to treat men and women the same. I think that's correct, but you do have a bit of a less certainty about this in women compared to men because of their lower participation in these clinical trials. Now, the guidelines don't have a difference between men and women. Yet, when we look at the actual implantation of these devices in men and women, we see very consistently that women are offered these devices less often than men. And so if you are female, and here I use the term gender specifically because there's nothing biologically that should make a difference in how we handle this, but this is how women are treated by cardiologists and electrophysiologists. You can see that they are much less, this is 30% less likely to get a device and to get an ICD of 40% less. And that's quite a remarkable difference. Looking at Medicare patients and looking at ICD implantation rates. So these are men and women who have guideline indications. They should get a device. And yet, when you look at the implantation rates, you can see they're almost 4-fold higher in men than in women, or a little over 3-fold higher, I should say. And so it's really a remarkable difference. Secondary prevention. Now, when I say secondary prevention, as I mentioned, you've had a cardiac arrest, you've survived, and now we should implant a device so that we don't risk you having a second event and not surviving that one. In a case like that, there ought to be 100% implantation or close to it, with some caveats based on whether you have other conditions that might compromise your long-term survival. So absolute indications for implantation of a potentially life-saving ICD, and yet the implantation rates are still 2.5-fold higher in men than in women. And here there's a very clear-cut impact on survival over a short period of time. Get with the guidelines, that's the GWTG, looked at hospitalized patients who to look at disparities in the care of men and women. So these are hospitalized patients with heart failure. Ejection fraction is how we measure heart function, and being 35% or low is abnormal, it's low. And these are patients who meet indications for getting an ICD. And here you can see that women were less likely than men even to hear about whether or not they could get an ICD or should consider getting one. So it's a lower rate. If they did get the counseling, men and women were equally likely to say, yes, I want to go ahead and have that because I want to get protected. And the same goes for ethnic minorities that we've looked at. There's another kind of implantable device. The one I mentioned already is to provide life-saving therapy in the case of a cardiac arrest. CRT is cardiac resynchronization therapy. And here there are some clear-cut differences. Whereas with the ICDs, you say, do women really benefit as much as men? Actually, the opposite is true for this kind of therapy. What cardiac resynchronization therapy is, in broad brushstrokes, is you have people with heart failure. Their hearts are not well synchronized based on things we can see from the ECG. For the medical people, it's wide left bundle branch block. And by putting in two leads in the heart and resynchronizing the left and right sides of the heart, we can resynchronize the heart, and it improves heart failure and improves the ejection fraction. So this is a study that I did with, again, one of my former cardiology fellows, looking at outcomes from a study called Miracle, which was one of the early studies looking at the impact of this kind of therapy on patients with implantable, who got this cardiac resynchronization therapy. And we looked at 6-month outcomes. In here, patients were being randomized to either getting the cardiac resynchronization therapy or not. Let's see, this is a pretty common find. This is a very regular finding, actually, that if you look at patients who have ischemic heart failure, which means coronary heart disease, heart attacks, scar on the heart versus other reasons for weak hearts, men are more likely to have that kind of ischemic heart failure and women less likely. But here's the key finding. If you look at important outcomes, time to death and heart failure events, you can see that on the left-hand side, what this shows is that if you were the control group and didn't get the resynchronization therapy, the percent surviving without events dropped pretty quickly, whereas the ones who got this new therapy survived very well. If you looked at men, there really wasn't much of a difference. So if anything, you ought to have higher rates of implantation in women. A lot of this, I believe, is due to the difference in the kind of heart failure that women have. But even when we controlled for that, we saw a difference. I can get into that in a little more detail, but I do think it has to do with the fact that, as I showed very early on here, that the QRS duration in women is shorter than men. So when you have men and women who both have QRS prolongation, it's relatively bigger difference in women than men, and a relatively bigger chance that they're going to benefit from this therapy. This is another way of looking at changes. These are different. What these are parameters of chamber sizes in the heart, showing that when the bars go down, it means basically that the heart shrunk, got smaller. And if you have heart failure, that's good. We want that to happen because a big baggy heart doesn't beat well. A smaller resynchronized heart is going to be more effective at pumping blood through the body. Okay. These are some data from a couple of different registries. This is from a heart failure registry, inpatient. IMPROVE-HF, this is something I was directly involved in on the steering committee. And this looked at process improvement for treating patients with heart failure in outpatients with heart failure. The one on the left shows about racial disparities, but I'm going to concentrate now on, because of what this talk is about, is on the gender differences in different kinds of registries that we have. So nationally, we looked at that, and this is not my study, but another one, looked at millions of patients actually. And we do see gender and racial disparities here. The rates of implantation, you can see, are much lower in women than in men for these kinds of devices. And I think for the sake of time, I'm going to move on a little bit here. But if you look at implantation rates by sex, or maybe I should say gender in this case, women were less likely to have ICD. So again, a much lower percentage. And even after you adjust for a variety of different conditions, age, other comorbidities, that sex difference persists, and it's quite profound. And this just got published this year. It's a real world assessment. So we have clinical trials, and they're very controlled environments. You would hope we'd have more equal distribution of men and women in these trials, but we don't. But when you look at the real world, or in other words, across just the general practice of medicine, what happens when patients are indicated for these devices, and do they get them or not? One way to do that is by looking at what we call real world data and these disparities. And so this is actually a very new tool in medical research, and it's called computable phenotypes. It's a little bit difficult to explain, and I really don't have the time to go through it. But basically, I think as most people, we have electronic health records today. So the days of writing things by hand are, well gone. And in electronic health records, some things are very easily quantifiable by clicks of different parameters. Others are typed in. And so computable phenotype is a way of putting together a computer program that can go through the electronic health record and pull out information on patients, whether it's typed in or it's in fields that are a little bit easier to access by a computer. I like to look at it as sort of having an electronic fellow working for me. So instead of having a resident or a fellow or anybody else in medicine go through the charts and look at each of these things and write down who's got what kinds of conditions, the computer can do it for you if it's set up correctly. And if you do, you can get a lot of information out of millions of patients, whereas with humans doing this, you can really only look at hundreds in a practical sense. So this is from the GLIDE-HF registry, which stood for Guideline Indications Detected in the Electronic Health Record for Heart Failure. And we went to look at guidelines for patients getting ICDs, and this is from the 2012 guidelines because of the time frame we were looking at here. And we wanted to look at treatment with ICDs or this cardiac resynchronization therapy among patients who now meet guideline indications across race and sex groups. So I'm showing this again. So this is saying we're using these computable phenotypes where we say input into the computer what the guidelines say you should do, and then do the analysis of the patients. And the phenotypes are the people who are indicated for these devices. And then you get knowledge out of that by comparing guideline indications versus what's actually happening so that we can predict and classify these things and then intervene if appropriate. So this data set has 1.54 million patients in it. That's why it's such a rich source of data. Anonymous patients and providers, so it's HIPAA compliant. It was across 47 healthcare networks, and it had all of this information in it that we could access. And what we found by looking at these data, men received defibrillators more frequently than women. You can see that, and this difference is significant, and that's shown here. And we also saw racial differences highlighted on this slide. So across the board, if you're a white man, you're much more likely to get these devices than if you are from underrepresented minority or women. And this shows it broken down a little bit more by, and actually the real problem is that a lot of patients who are indicated are not getting these devices at all. But if you look at the ones who actually did get implanted, white males trump every other category that we have. We looked at the interaction of race and gender. And as I mentioned previously, white men are much more likely to get a device than any other group you can look at. And I cannot explain the observation of Asian women. I mentioned briefly a few minutes ago about IMPROVE-HF, and that is the outpatient registry that I was part of that looked at outpatients with heart failure at baseline to say, are they getting guideline indicated treatments? And these were drugs as well as devices. Got a baseline look at this. And then had a process improvement intervention. So workshops and reminders and cards to look at and training to make sure that the providers, the physicians taking care of patients, if they weren't doing all the guideline indication treatments, would hopefully improve. And then looked at a couple of different cohorts over time, looking at one cohort at 12 months and 24 months, and then different cohorts at 6 months and 18 months to see if there was an improvement. So this is quality improvement, the definition of it in the outpatient setting in these heart failure patients. Now, this process improvement exercise or registry looked at a bunch of drugs, which I'm not going to highlight here. I'm concentrating now on ICDs, which have been the subject here for a while, and the cardiac resynchronization therapy. For CRT, there was no difference based on gender, which is good because, as I mentioned, women have at least as much benefit as men. But we see the difference between men and women where it comes to implantable defibrillators. Here shown the data in a slightly different way. I mentioned there were baseline rates where you could see that what the differences were. I'm sorry, the cardiac resynchronization therapy was pretty comparable, but a big difference in ICDs. Then at 24 months, the rates improved, and you can see that the rates improved relatively more in women than in men. So we were getting closer to where we need to be by doing this kind of a quality improvement performance exercise. There are a lot of differences. There are important things to know about pregnancy. It would be a topic in and of itself, so I can't really talk about that now. But there are differences we see in normal pregnancies. Women who are pregnant have higher resting heart rates than men do. They're more likely to complain of palpitations, really not anything to do except to monitor patients and provide supportive care. But there are some arrhythmias that become more common in pregnancy. And probably one of the most important things I would say is that if we know that patients have any of these sustained arrhythmias from the SVTs that I mentioned before that become problematic during a pregnancy, I always tell the patient afterwards, we usually try to not fix them, put them through catheter ablations until after they've given birth, but certainly get it treated before you have a subsequent pregnancy. So in conclusion, there are significant sex-based differences in the incidence, prevalence, and clinical characteristics of arrhythmias. The outcomes, though, of pharmacological, so drug therapy or non-pharmacological therapy, such as devices or catheter ablation, the outcomes are similar in men and women. So there is no reason to treat men and women differently based on any of these findings. However, advanced therapies such as implantable devices or catheter ablation are either offered to women at a later stage in the course of the disease, or they're not offered at all at the same rate as men. But then the good news is that performance improvement initiatives are effective in improving the utilization of guideline recommended therapies in both men and women. And I thank you for your attendance, and I will stop my screen share there.
Thank you so much, Dr. Curtis, for that fantastic talk. And what was so impressive to me, just looking at the dates of your publications, that you've been doing this research for a long time. And I'm thinking of the Heart Center, the Barbara Streisand Heart Center at Cedars-Sinai, but which is saying that the research is just beginning, but you've been really at the forefront of this for quite a while.
Yeah, I have had the opportunity to look at it for a long time, and there is still work to be done. It's been a big interest of mine.
So I want to open the floor for questions that we can also have dialogue going in the chat box as well, but I'll get it started just by asking the question about quality improvement exercises, because what you're really telling us here is a question of implicit bias, right? Particularly for women of color, not getting access, not getting the education or counseling on it. I was just interested in how is it, as an educator in a medical school, do you work with students and residents to try to counter implicit bias? And I guess I'm asking about the quality improvement exercise that you implemented.
Yeah, those are very important. The good news is that our trainees, so when you get into residencies and fellowships or after you graduate medical school, it's required that that quality improvement work is done. And so a lot of the trainees do tend to get into these projects. not specifically this necessarily, but other ways of making sure that we improve care. And I do think that being cognizant of these sex and gender-based differences, as well as in race, we've got to be mindful of them. Some of this is also, sometimes we find that it comes from the patient standpoint too. So, women are caregivers, right? And I'm taking care of my elderly mother. I'm taking care of my children. I can't afford to take time out for myself to get things done, or I'm going to, put myself last. We have to encourage women not to do that, that they deserve the right, they deserve the right care for themselves too. So, so it's a little bit of that as well. It's the way women themselves view what they want to have done.
All right. No, that sounds familiar. Thank you. Any questions from the floor, from our wonderful audience here today? You can unmic yourself, or you can simply add it to the chat box.
I have a question.
Okay, go ahead, Omar.
Kind of related to something that was really interesting the doctor mentioned. It was a resource where she used the computerized phenotyping. I was wondering if that was available for things other than cardiology, or if that was like a data set that was only specific for that.
That's a great question. Because of the nature of it, it should be available to anybody. The problems where this has been accessed most is by industry, because there are some things like the National Inpatient Database and that anybody can access. Medicare, anybody can access. This program, the GlideH, the Pinnacle, the large program that I was talking about. I believe that you have to get permission, and there's a cost to it. So that's not as so it's accessible in the sense that you could probably study anything you want, but it's not as readily available to somebody. But there are other areas where one can look at that on a national level that does not involve a cost.
And the benefit of that would be that you could just search terms and it'll show you the data itself in comparison to other data sets?
Well, what you have to do, though, is you have to have the computable phenotype. So that's where, you can't do it. So when we did our project, we had to get somebody who knew how to put this together. So you get somebody who is good at biomedical informatics. And, we do have a department here, and they get very, that's something that they work on very, that's their thing. You actually have, basically you create the computer program. So you have to have somebody do that. And then once you do it, you can run it on the data set, and that becomes very easy. So for any of us, you'd have to have that extra piece where you'd have to have somebody, sort of figure out how you want to look at the data. So for example, I can figure, I don't have to do anything to figure out how many people have ICDs. But if I want to say how many patients who were indicated for one got it, then I have to have in the computer program, what's a class 1 indication? What are the parameters that I have to look at? So that's why you have to create a program in order to do that. And you need to partner with people who can do that. I would say an ideal group is, anybody who's in medicine now, whether you're going through, whatever residencies and fellowship training, there are some people who are getting biomedical informatics training and even fellowships. And those people are going to be ideally suited to do this kind of work.
Very good. We have just a question in the chat box from Joan Baser. What percentage of cardiologists are women?
No more than 20%. So we are very much underrepresented. In the field of electrophysiology, which is my field, it's 10%. And so, I'm glad you mentioned that, because if you look at, medical students today, it's 50% women. If you look at internal medicine training, it's about 50% women, but many fewer women choose to go into cardiology as a field. That actually has been studied, and there are publications on that. And there is a perception that cardiology as a whole is less female friendly, with call schedules and things like that. To go into electrophysiology takes additional training beyond even cardiology training. And so we really have a very low percentage of women who go into it. I've been co-chairing a group called Women in EP, or Women in Electrophysiology, for about a quarter of a century now. And so, you know, it's sponsored by industry, but we have a meeting once a year where we invite women to participate in the meeting and to give talks, to be a networking opportunity, so that especially younger trainees can see that it's a very rewarding career, and we'd like to see more women go into it. So, but we still have very, very low numbers across the board.
Okay, that's unfortunate. Any other questions coming up? I wanted to ask a question about COVID. You type in cardiology and you type in various conditions like cardiac arrhythmia, and it says with COVID on Google. And I just wanted you to address that. There was just this week, Julie Powell, the writer of Julia and Julie, the Meryl Streep movie and all that. She died suddenly from cardiac arrest at 49. She had COVID in September, was very vocal on it about Twitter. And there's been a huge discussion right now on social media about the relationship between the two. And I just was wondering, as a specialist, what you have to say about that.
Oh, wow. I hadn't heard of that. That's very interesting. Yes, when patients have COVID, it's possible to get myocarditis. So myocarditis is an inflammation of the heart muscle. You know, you can pick it up. I mean, some people have mild cases of it and they're asymptomatic, but it can, you know, create symptoms such as chest pain and fatigue and shortness of breath. But a severe case of myocarditis, if you have inflammation of the heart, it could trigger one of these potentially lethal arrhythmias and not survive it. So yes, and we're also seeing other kinds of arrhythmias with patients who are post-COVID. Some patients are presenting with atrial fibrillation for the first time. And that by itself, that's not a fatal arrhythmia. So I don't want people to get panicked about that. I mean, there is a risk related to stroke there, but the bad ones are the sudden cardiac death and the ventricular arrhythmias, like I mentioned before. But yeah, that's a real tragedy, and fortunately extremely rare. So
Okay.
Good to know.
All right. Thank you. Our Deputy Director, Joe Freudenheim in Public Health, asked the question, what initiatives for increasing the number of women in the clinical trials are there?
Yeah, no, I think that's really important. Well, today, when you submit any kind of clinical trial to the NIH, they want to know, you know, I mean, there are specific places where you've got to say, how are you going to make sure you have enough, you know, representation of women, and how are you going to make sure you have enough, you know, that there's a broad racial distribution. And so, you know, that means that, you know, so in order to be grant funded, you have to have, you know, plans there. But then even as you're enrolling patients in studies, you've got to keep track of you know, who's getting approached about these things and in there. And at times you've got to then redouble your efforts. So for example, if it's a racial disparity, then you might engage you know, medical schools or programs that have a richer population of racial minorities. For women, it can be things like, you know, I think there's more of a role for women's programs in heart disease, I mean, women's health in general, but women in heart disease. And I think that's another way that we can get people into trials and hopefully enrich that. But I think it's so important to get women into these studies so that we can understand better the potential benefit from it. Yeah, as a matter of fact, you know, I forgot to put up my very, very last slide because I had some final thoughts on it. And the point I made was, what if 80% of the patients in the defibrillator trials and the cardiac resynchronization trials were women and only 20% were men? There would be some differences in the guidelines. Survival benefit from ICDs might have been a little harder to prove. I think the guidelines for resynchronization therapy would be a little more liberal because women have, you know, better, you know, outcomes from that. So, you know, that just speaks to why it's so important to try to get good representation in any clinical trials that we do.
Very good.
Has any correlation been found between COVID vaccine and heart problems? I don't
believe so. If so, very, very rare. I wouldn't, I'm sure if you Google it, you'll find something, but it's not known to be a common problem. The real risk is in actually getting COVID.
Any other questions? before I get to ask my final one to wrap up. All right, I will indulge, if you can indulge me on this, Dr. Curtis. I'm teaching Christine Montrose's wonderful book, Body of Work, to my first year seminar students. And it's about the journey of taking anatomy and what it's like to interact with the cadaver as a first year medical student. And it's a beautifully written book. She's a psychiatrist now, as well as a poet. But she talks about, when does life end? And the debate between the neurologists, it's the brain versus the heart. And my students just exploded into a debate about this, my first year students. And I just was wondering, I wanted to indulge, and I told them you were speaking at the Institute. How would you answer that?
Gosh, that's a tough one. Oh, I have to say the heart, right? I'm a cardiologist.
Right.
Yeah, I mean, you know, you can have a heart beating. I mean, if you can keep somebody going a long time with a beating heart without, cognition, and that's no way to live. And that's why we have a term such as brain death, and know that if there's no chance of recovery, that there's no point in keeping a beating heart going. I'll be diplomatic and say they're two of the most important organs in the body.
Okay, I'll share that with them tomorrow. Thank you so much, Dr. Curtis, for a brilliant talk. I thought you traversed the specialty discourse with the general language brilliantly, and I'm so grateful for you for being able to do that.
Thank you.
Thank you all for joining us. We'll be returning in December for our last FRA of the semester, so check out our website for details. Thanks, Sarabi, and you can join our listserv as well.
Thanks, everybody.
Yeah, thank you, Dr. Curtis. Fantastic talk.